Hello Health on LAE is presented by the Ochsner Health System, a nonprofit academic multi-specialty healthcare delivery system dedicated to patient care, research, and education. The Ochsner Health System includes 8 hospitals and 38 health centers located throughout southeast Louisiana. Ochsner, healthcare with peace of mind.
When Rose first started with us, she was just coming out of the hospital.
It's been a better situation. I can always depend upon her to help me. I'm home, and that makes me happy.
We're here to get her back into her routine and be able to live the life she wants to live. It's an honor to be trusted with that responsibility.
Good evening, I'm Tom Bagwell, and welcome to Hello Health, a partnership with WLAE, the Ochsner Health System, and Humana to bring Ochsner's Hello Health weekly education and information series to television. Tonight we're going to be talking cervical myelopathy, a condition caused by the narrowing of the spinal canal that can lead to serious spinal cord issues. Tonight's guest is neurosurgeon James Kalyvas. In the second half hour of our program, we'll be taking your questions live by phone at 504-866-3200. That's 504-866-3200. And you can send us questions by email. There's our address, hhquestions@wlae.com. Well, Dr. James Kalyvas got his medical degree from Columbia University in New York. He completed a neurological surgery residency at the Barrow Neurological Institute in Phoenix, Arizona. While he was there, he completed a fellowship in complex spine and spinal deformities. Dr. Kalyvas is a member of the American Association of Neurological Surgeons and the Congress of Neurological Surgeons, and it is our pleasure to welcome Dr. James Kalyvas to Hello Health. Good to have you with us on the program,
Thank you so much for
Doctor.
having me.
Yeah.
Thank you. Appreciate
So who's
it.
watching at home tonight? Tell us about your family.
My lovely wife, Lori, and our
Okay.
4-month-old Wyatt James Kalyvas. So.
All right, excellent. So speaking of family, your family had something to do with your interest in medicine, right?
That's right. Both of my parents have multiple sclerosis. They've had it for over 20 years. You can imagine that's pretty rare to have both of them have that disease. They didn't have it when they met each other. But I think it had a profound effect on my decision to go into medical school and then also to pursue a field in the neurological sciences.
And you didn't start in medical school, right? First you wanted to be in finance, work on Wall Street?
Well, actually, I always wanted to be a surgeon or a doctor of some sort growing up, and then I took a detour after college. I went to New York to work for a couple of years on Wall Street. My parents actually loved that idea because I was making money right away, but it wasn't a passion of mine. You know, I wanted to interact with people and help people the best that I could. And so, you know, medicine just sort of called back to me. So I went to medical school, and I'm so glad that I did.
And what about the surgery part of it? You chose to be a surgeon.
Yeah, you know, I'm kind of a hands-on type person. I'm somewhat artistic, at least I like to think so. My wife may disagree. But I enjoy painting and drawing and working with my hands, and so that's a natural fit with surgery.
Very good. So let's talk about cervical myelopathy. Exactly what is it?
Well, cervical refers to the region of the spine and the neck. Myelopathy literally means disease of the spinal cord. And so we're talking about cervical myelopathy, but specifically degenerative cervical myelopathy. And by that I mean compression of the spinal cord that results from wear and tear in the spine as we get older. So overgrowth of bones, joints, discs, all the anatomic components of the neck. We're not talking about spinal cord compression that results from other things, tumors, or other diseases you may have heard of, like multiple sclerosis.
If they have this?
There's a characteristic set of symptoms that are associated with myelopathy. Hand clumsiness, and typically I ask people if they've been dropping things with their hands more frequently. Difficulty with pocket change, hand. The other is imbalance, so difficulty walking, falls, near falls. That's a pretty common one. And then the last one are urinary problems, and that can range anything from hesitancy or urgency, meaning having to go more frequently or very often, including at night, to frank incontinence, accidents on yourself.
And what about these other symptoms we have listed? Numbness, weakness, those sorts of things, pain in the arm and neck?
All of those things really, particularly numbness and tingling in the hands and feet, weakness or atrophy, which refers to shrinking of the muscles in the thighs and in the hands and so forth. Now, neck pain and arm pain are often a reason that people come see me in the office, but they're not always associated with myelopathy. To make an extreme example, you could have complete loss of function of your spinal cord and not be in any pain whatsoever. So some people are surprised to find out they have cervical myelopathy even though they don't have neck pain or arm pain.
How common a problem is cervical myelopathy?
It's the most common cause, or one of the most common causes for surgery in the cervical spine. About 200,000 people are living with it in the United States. And I would actually argue that it's underreported. I can't tell you how many times I've had patients come in to see me for other problems, low back pain and so forth. And during the physical exam, I uncover something wrong with the neck. And so it's a really common problem, and I think it's underreported. And it's something that's going to become more common as the population gets older.
Okay, let's look at some pictures now. Take us exactly where we're looking at the neck and look at the biology.
Right. So this is a lateral view of the neck on MRI. So the left side of the picture is where the face is, and the right side is the back of the head. And we're looking at the bottom of the brain and the spinal cord there. That dark gray stripe is the spinal cord. And surrounding it, you'll see a white fluid. That's cerebrospinal fluid. And then to the left, you see the bones of the neck. They're the vertebral bodies, and in between them are the cartilage discs. People often have heard of herniated discs and so forth. That's what they're referring to, is these cartilage discs that act as the shock absorbers in the spine. And then importantly, it's a little bit hard to tell in this picture, but I'm pointing to the important ligaments that are often involved in cervical myelopathy. Just behind the vertebral body, there's something called the posterior longitudinal ligament, and just behind the cord, something called the ligamentum flavum. We'll talk more about those because they're important to the disease process.
And when someone has CM, what would look different here if I was looking? And I know we have other pictures.
Yeah, we have other pictures we can show, but you would basically see that some of these structures are overgrown or out of proper position, and you'll see compression of the spinal cord, sometimes with swelling of the spinal cord in severe cases.
And are these usually normal wear and tear items, or is it trauma to particular areas? Trauma
is really kind of a separate process. With degenerative cervical myelopathy, we're talking about things that have occurred over decades, certainly years. It occurs as you get older, and I'm specifically referring to something called osteophytes, or bony spurs that people have heard of, bulging or herniated discs, calcification of those two ligaments we just talked about. And then kind of a separate category is some people are born with narrow spinal canals, and that really sets them up for developing myelopathy from these other reasons like discs and bony osteophytes.
Okay.
There's also dynamic compression. So by that I mean you may look at an MRI and not see compression of the spinal cord, but as the patient moves their head, they may get compression with movement. And so we always look for spinal instability or abnormal motion in the neck that may lead to compression.
And what do we see in this final image?
This was a schematic in a recent article in the literature, which I thought illustrated all the different types of compression we can get. In the top image, we see on the left an osteophyte. That's a bony spur causing compression of the spinal cord at the front of the spine. And you can see the spinal cord compression that I'm pointing to. There's a cyst formed within the spinal cord in this example. We often see swelling and damage to the spinal cord itself. Just below that, you can see a herniated disc. That also usually causes compression from the front. And then down below, we see the ligaments. Typically, we see overgrowth of the ligaments or buckling of the ligaments that causes compression, but in extreme situations where it's been there a long time, you can see it actually turn into bone. We call that ossified posterior longitudinal ligament or ossified ligamentum flavum.
Okay, so this is wear and tear. I'm assuming mostly normal wear and tear, which brings up the question, is there anything we can do to avoid these types of problems?
Well, it's mostly age, as you say, so that's a good thing. We want to get older, right? But gender, occupation, certain neck injuries can set you up for cervical myelopathy. There's certain genetic factors, and by that I mostly mean that narrow spinal canal we talked about. So your anatomy may set you up for it. And something that most patients don't know is that smoking directly degenerates the spine. It really restricts the blood flow to the spine, which directly leads to wear and tear and, in some cases, compression.
When you say gender, and you chose a woman there, and I'm not sure why, but do women get this more often than men? Do we know why?
We don't know why, but it is true that women tend to develop myelopathy more than men do. But I have to say that I see plenty of men that also have it.
Okay. And women who wear scarves, you tend to, that was our little joke.
Yes, frilly pink scarves like in the picture.
Scarves have nothing to do with any of this.
No, nothing.
All right. Well, if you have these symptoms, how would a doctor diagnose this condition?
I routinely ask, almost as a screening question in my spine interview with patients, about things like hand clumsiness, balance problems, urinary problems, and so forth. And so based on the history of symptoms, my suspicion goes up. And then I move on to the physical exam. And here, this is a situation where the physical exam that we do in the office is incredibly important to diagnose this. And by that I mean, what does their walking look like? We do the drunk inline walking test. And if they have, real difficulty with that, that means...
Which is not easy, even if you're not drunk.
And we're in New Orleans, so
right.
They may have had one too many, or they could have a problem in the cervical spine. Also, reflexes are really important, so abnormal reflexes, exaggerated reflexes, and I have a video that I want to show you that illustrates that. But also abnormalities in sensation and strength, all are indications there might be something wrong in the neck.
Before we get to the videos, we are going to show this in just a moment. Do you look at posture too? How someone holds their neck in relation to the rest of their body? Absolutely.
So I'm a deformity spine surgeon dealing with complex spine issues, and the shape of the spine is really important. We call it kyphosis when the normal curvature of the spine is reversed. So normally the curvature of the spine is like a C shape, okay? But when you get kyphosis, which is really just advanced degeneration, you can have reversal of that C shape, and that can lead to stretching of the spinal cord and also problems.
Okay. You talked about reflexes and abnormal reflexes, and you brought along a couple of videos.
I did.
So what do we see in this first one?
So this is an example of an exaggerated reflex, specifically looking at the patellar tendon reflex. And as the reflex hammer hits the patellar tendon, you should see a pretty muted response. That first one you saw, this one, is a pretty normal response, does not raise suspicion for any problems. But here we see on the right a really exaggerated response. That's not a normal response, and also the asymmetry of it is concerning as well.
Okay, that's dealing with the knees. The second one looks at the fingers.
Right, and so this is an example of a pathologic reflex called Hoffman's test that we do looking for a reflex that you normally shouldn't have. So when someone flicks the finger, the other finger shouldn't move. But you can see in this example, when we're flicking the finger, the other fingers flex forward reflexively. And that's an abnormal response that's concerning. It's more concerning if it's asymmetric, only in one hand.
Okay, so that's what it looks like when a patient has a problem. We pre-tested this, and I
Yes.
don't.
Yes.
So, but we did want to show people what that looks like on a normal hand.
So I extend the finger, and then with the flicking motion here, I'm assessing the other fingers, and I can see that there's no abnormal motion here at all. And so you pass this test.
All right.
We'll keep looking.
All right. What are the images and diagnostic tests that you would use once you've moved past these reflex tests?
Mm-hmm. The gold standard is really the MRI. The MRI has really advanced our understanding and I think increased our recognition of the disease. It gives us a great picture of the spinal cord, the soft tissues, and all the sources of compression. So that's really probably the most common thing that we want to look at. But not everyone can get an MRI. And there's another study, the CT myelogram, that's better for looking at bones and so forth. So that's probably the second study in our armamentarium that we look at. Now, lastly, we have the dynamic x-rays, and by that I mean x-rays of your head in motion, flexed forward and extended back. There we're looking for dynamic compression. So any abnormal motion, that may lead to compression of the spinal cord.
Okay. What are the risks if someone is diagnosed with cervical myelopathy and just says, doctor, I'll get around to it, I just don't have time to deal with it right now?
So the risks are that it progresses, okay? And typically what happens is progression occurs in a stepwise fashion. That's at least the classic teaching. Everyone follows their own course. It's a very variable disease. But by a stepwise decline, I mean there may be periods where your symptoms are completely stable, and then periods of time where you have a dramatic decline in function. And about 2/3 of people will fall into that category where they deteriorate, but it's really hard to know who's who. And this has been looked at in the literature over and over again. It's very, very difficult to see who's really at risk for progression.
All right. Is it something that has to be dealt with surgery, has to be treated with surgery?
That's a question I get all the time. There are non-surgical options like wearing a cervical collar or physical therapy. Those might be options in the setting of compression that happens with movement. So you stabilize the spine either through exercise and strengthening the muscles or with a cervical collar. But by and large, this is a surgical problem. There's mechanical compression of the spinal cord that needs surgical decompression. And over again, surgery has really been shown to make a meaningful improvement in patients' lives, their function, their disability, and quality of life.
Are patients likely to see their symptoms improve through the surgery?
That's a very important question because I'll often make the recommendation of surgery and patients will ask how soon they'll get better. It's a valid question, but I think a more realistic goal is we want to stop the deterioration. So we said without surgery, you're likely to get worse over time. So our primary goal is with surgery is to stabilize those symptoms. Now, it may be that you recover function over time. The spinal cord takes a while to recover, it usually takes about a year, and again, only about 2/3 of people actually improve. Third goals and fourth goals are improving spinal alignment if there's a problem, or improving neck or arm pain if that's associated with it. But those are trickier. The primary goal is really just keep you where you are. The spinal cord is kind of like a one-way street. You can lose function. It's very difficult to get function back, unfortunately.
You hear about patients who go to see a cardiologist and get a test and say you're at 90 to 95% blockage, you'll be in the morning for surgery. In fact, you might even be in within a couple of hours. Is this type of thing an emergency?
I would characterize it as an urgency in most cases, but it really depends on the situation. It depends on how severe these symptoms are, how long you've had them, and is it progressing? Are your symptoms getting worse actively? And that's really the fundamental question that helps inform my timing recommendation. So if this is something that's happening quickly, you're rapidly getting worse, that's more urgent. Sooner in general for this disease process is better. But if you have a mild case and things are relatively stable, we may choose to watch you for a period of time.
All right. Let's talk about the two approaches to surgery.
Well, there's an anterior set of approaches and posterior set of approaches, and there are different scenarios for each. The most common anterior approaches are the anterior cervical discectomy and fusion. We call it the ACDF, or just the ACD. And this is the most common surgery done. It's the most common surgery done in all of neurosurgery, actually. There's a newer surgery from the front called cervical arthroplasty. So instead of a fusion procedure, you're replacing with an artificial disc. And for really extreme cases of compression that's involving the entire vertebral body, not just the disc, corpectomy is another surgery. We'll talk a little bit more about the ACDF in a minute. Then from a posterior standpoint, really the bread and butter surgery is a cervical laminectomy, where you remove the bone, the back wall of bone, from the spinal canal, and then you reconstruct it with rods and screws, the fusion portion. There's another procedure done called a cervical laminoplasty, which is also pretty effective, where you just replace the back wall of bone once you've thinned it out.
All right, let's start with the ACDF, and you brought some images along to show us.
So this is an example of an MRI on the left, where we see some spinal cord compression from a disc bulge. Okay, so that's compression that's coming from the front side of the spinal cord, and really that moves me to do a surgery from the front. So in here, an ACD, and you can see the planned incision that we do. It's kind of a horizontal or transverse incision on the right side of the neck. Cosmetically, it heals very, very well. And the next picture is a schematic of the actual construct. So we're removing the disc material to decompress the spinal cord. That's the priority. And then we're reconstructing the spine with a spacer and a metal plate with screws. That holds everything together. And you can see the x-rays there, the lateral and frontal x-ray showing that hardware on x-rays and what it looks like.
You mentioned that it heals well, the surgery and the scar. Is that usually going to be, or can it be, underneath the shirt line?
Sometimes for really low level, meaning lower cervical spine pathology, but typically it's hidden within a fold. All of us have natural creases in our skin and the neck, and we try to hide it in one of those.
All right. Let's talk about the other now, the laminectomy and fusion procedures.
Okay, so this is for situations where we have compression over a broader area. It's not just one segment or two segments or maybe even three segments, but it's broadly compressed and compressed from the posterior or back of the spinal canal. This is a good example of an MRI with that. And then also in the schematic, we have the incision there in the midline of the neck. Tougher to hide. Tougher to hide, right. That's true. If you have long hair, then it's typically okay.
Like I said, tougher to hide. But anyway.
That's right. And this is a schematic that we're looking at where we're doing the laminectomy. So that laminectomy refers to that back wall of the spinal canal, and we're essentially unroofing the spinal canal to create more room for the spinal cord. The x-rays shown are what the hardware looks like. So after we've removed the bone, we need to stabilize the spine again. We do that with with rods and screws.
Okay. Now the doctors brought along a video to show us. We're going to show it to you in just a second. We do want to let you know that it is a video of surgery, and we're around the dinner hour. So if it's something you'd rather not see, and it's not very long, about 7 to 10 seconds or so. So if you're watching tonight and you'd rather not see the actual surgery, we'd ask you to close your eyes for just about 10, 20, 30 seconds. In fact, I'll tell you when it's okay to look again. But the doctor felt it was important to bring the video, and we're glad that he did. So close your eyes if you'd rather not see it. And doctor, well, I'll tell you what, before we view it, tell us exactly what we're going to see, because it's not very long.
Yeah, it's a pretty short video. Unfortunately, it's a little grainy, but it's a real-time video that we did just last week. This is a laminectomy, so an incision in the back, removing the back wall of bone. And you'll see us how we remove the bone sort of in one block. We're removing it carefully, methodically, and you can see the spinal cord underneath as it's getting decompressed.
Okay, we'll ask you to close your eyes now. We're going to take a look at that video right now.
So here we're drilling troughs into the bone to disconnect it, okay? And now we're slowly lifting that back wall of bone up, and you can see underneath the spinal cord as it's getting decompressed. In this picture, the head is towards the right and feet are to the left. Really see how the spinal cord gets decompressed well there. And we have a photo showing the post-operative view.
Yeah, I think we've got a view here. See what it looks like.
Yeah, so this is the same surgery after we've done the decompression and we've placed our rods and screws. This is what it looks like in surgery.
All right, very good. Feel free to open your eyes if you did have them closed. And this is the time that I invite you to call us with your questions for Dr. Kalyvas. Tonight we're talking about cervical myelopathy. Our phone number is 504-866-3200. That's 504-866-3200. Or you can send us questions by email too. Here's our address, hhquestions@wlae.com. So doctor, you talked about the different surgeries and approaches. How do you decide or what role does the patient have in deciding which surgery you're going to go with, if surgery is the best option?
You know, there are a lot of circumstances where either one will work, and this is a debate in neurosurgery circles about which is the best approach. In general, if the compression is in the front of the spinal cord, we like to go anteriorly. I think it makes sense. You go where the compression is. And posteriorly, you go where the compression is posteriorly. There are a few advantages of coming from the front. One is that it's less painful than going from the back. And it's really good at also helping with shooting arm pain. So the cons of that are that you often have swallowing difficulty. That's really relevant for older patients. You can have a hoarse voice. That's true in most patients. And it's really for situations where there's 1, 2, or 3 levels of compression. Now, posteriorly, that's good for more diffuse kind of compression that comes from the back side. The advantage is you get a wider decompression of the spinal cord than from the front. The downside is that it's a more painful procedure than the ACDF. And that's because we're retracting on the muscles of the neck for a relatively long period of time. The muscles get sore, but that pain is temporary and patients do very, very well with that approach. There's also a slightly higher risk of infection.
Oftentimes, a surgeon will tell us if there are different approaches and they both yield the same results, ask the surgeon which they are more comfortable with and which they prefer, because they're the ones actually doing the work. Do you have a preference of these two, or do you feel just as comfortable doing both?
I think that's good general advice. I think I would choose a surgeon that's comfortable doing either, because there really are rules for each. I should say that there's also very common surgeries, both the front and the back. So.
Okay. Well, in summary, what have we learned tonight?
Well, I think that without treatment, natural history of this is a variable course, but by and large, a stepwise loss of function in the arms and legs, possibly urinary problems, that happens over a period of time, usually on the order of months to years. Surgery has been proven to be very effective for stabilizing symptoms, and in a lot of patients, improving symptoms, but we've got to remember that that takes time. The spinal cord really takes about a year to get better. And then the surgical approach is really up to the individual patient's anatomy, their symptoms, and surgeon expertise.
All right. We're going to take a break, but when we come back, we're going to have your questions. 504-866-3200 is our number. Again, 866-3200. Or email us questions at hhquestions@wlae.com. Back with your questions in a moment. This is Hello Health on WLAE.
I love taking care of my mom. It wasn't easy at first. She learned how to better communicate her needs.
And you learned how to not ignore yours.
I discovered how to make healthier meals.
And I discovered how much I enjoyed them.
Becoming a caregiver is a learning experience for everyone. Find articles, tips, and tools from experts and others who have been in your place. The Caregiving Resource Center at aarp.org/caregiving.
And welcome back to Hello Health. I'm Tom Bagwell. Good to have you with us tonight. We're talking about cervical myelopathy, narrowing of the spinal canal that can lead to serious spinal cord issues. We're discussing those tonight with Dr. James Kalyvas. You want a surgeon who's comfortable with these, and typically how many surgeries would you do in a week, and what does your schedule look like?
Yeah, I would say I do 1 to 2 anterior approach surgeries and 1 to 2 posterior approach surgeries for this problem a week.
Okay. And how often do the surgeries usually last?
The posterior surgeries, it always depends on the number of levels involved. The posterior surgeries, by and large, are slightly longer than the anterior approach surgeries. Anteriorly, I'd say about 1 to 2 levels for a 1-level problem, 3 and 4 hours for more levels. And then posterior surgery, it's more like 2 to 3 hours or more. But I always tell patients not to fixate, because I always give patients a rough estimate of time, not to fixate on the time. I know it's difficult to do, but just whatever it takes. Everyone is different. Every surgery is different, as long as you're doing it carefully and methodically.
You're probably saying that more to the family members who are in the waiting room.
Yeah.
You tell them 2 to 3 hours, and 4 to 5 hours later, they're
Right.
thinking, "Oh my gosh, something must be going wrong."
Right.
And in turn, it may just be a little more difficult than you thought.
Right, and I'm really quoting my actual surgery, my part, my role. I'm not referring to the time it takes to transfer the patient and put the breathing tube in and so forth. So it's variable.
Okay. Let's go to our phone lines. Bob is our first caller tonight, calling us from River Ridge. That's where we are, by the way, in River Ridge this evening. Bob, you're on line 1, and you're on Hello Health with Dr. James Kalyvas. Welcome.
Hey, good evening.
Good evening.
I had a quick question. Is it possible that a conservative approach, like physical therapy or some of the therapies, would help relieve some of the symptoms?
Thank you very much, Bob.
I think the question was, can physical therapy help alleviate some of the symptoms? It can, but a lot of the weakness isn't just weakness in the muscle itself. It's the signal from the nerves to the muscles that's the problem. And so I would say, by and large, I'm not against physical therapy in any way. I encourage most of my patients to do it, but this is really a surgical problem. And physical therapy is limited in this case of what it can really achieve. The one exception to that is if you have instability of the spine. So if you have instability, which is usually a result of loosening of the joints and ligaments, then physical therapy, by strengthening the muscles, can make the spine more stable and may help things.
Yeah, we talk about people with back problems, and we talk about strengthening the core muscles.
Right.
Are there muscles, we talked about preventing this sort of thing from happening. It's going to happen to all of us at some point due to wear and tear. But are there neck muscle exercises you recommend and others recommend?
No specific neck exercises per se, but I think a strong core, good posture, staying physically active, keeping the weight down, not smoking. Those are sort of lifestyle choices that you can do to really set yourself up well.
Okay. With any surgery, there are risks associated with them. What about these particular surgeries we're discussing today?
Yeah, so with the anterior approach surgeries, I kind of mentioned it, how swallowing problems are really common, and I'd say 99% of patients have swallowing problems for the first couple of days, and then it gets better. Only rarely have I seen situations where it's been longer than that, and in those situations, we do other things to get them nutrition. So swallowing issues, hoarse voice.
And again, is that temporary?
The hoarse voice is also temporary. In some circumstances, we need to look at the vocal cord function and the health of those prior to surgery to make sure that there's not going to be a permanent problem. And then posteriorly, it's really infection is the biggest one. But we're operating around the spinal cord. And so in the back of the surgeon's mind is always concern about weakness caused by surgery, worst case being paralysis. And so, we monitor the spinal cord throughout the procedure to make sure that it's healthy, functioning well, and not negatively affected by the surgery.
Talk to me about the team of people you would have in surgery with you for these types of procedures.
Well, for the straightforward cases, it's typically myself. We're a teaching hospital, so we include the residents, all the important nurses, circulators, and scrub techs that are there helping, and then, of course, the anesthesia team. For complex cases, I often involve one of my colleagues, Dr. Celestri, of orthopedic spine surgery, to really tackle those cases together. Because we think that it improves, reduces operative time, improves blood loss and patient outcomes.
Okay. Our phone number is 504-866-3200, and you see it there on the bottom of your screen. We do have phone lines open. Again, at 866-3200, area code 504. We're also taking your questions by email at hhquestions@wlae.com. Here's an email we've received. Doctor, I'll read it for you. What is the recovery time for surgery, and how quickly are you back to normal? And how long are you typically in the hospital? And we'll stop there, and then I'll get to the last question here in just a moment.
Okay, so, I really want patients up and walking the day of surgery or the day after surgery. Walking and getting back to normal life is vitally important. Everything we can do to get you out of the hospital as soon as it's safe to do is really to your benefit. And the criteria I use for getting out of the hospital are that you're walking, going to the bathroom, tolerating food, reasonably pain controlled. Sometimes we leave surgical drains. Those need to come out. And then once you're out, you're often wearing a cervical collar after surgery, so a hard, rigid collar around the neck. And you're recovering from surgery. I want you active, I want you walking, but that you have to use a little bit of common sense and not jump back into life full bore. Take it slow and let your body sort of dictate.
You're not fully functional. You're not going back to work the next day.
I tell people, give yourself at least 6 weeks. I will visit with patients at 2 weeks to look at the wound and evaluate it, and then 6 weeks again to see how they're doing. And at that point, they should be starting to get over the surgery itself, and we can reassess. But typically, I'd say patients are getting back to their normal life by then.
Okay. Let's go back to your definition of success again, which is stabilizing the symptoms, not necessarily improvement, although that does happen in some cases. So what is the success rate? And go ahead and recap that for us for people who may just be joining us. What is success by your definition and the definition of patients, and how often are these surgeries successful?
Right. So success here is stabilizing the symptoms. So the natural history of this disease is to lose function over time in the arms and legs and bladder. And we want to stabilize that. So success is really a year after surgery if things have stabilized or improved. That's my definition of success. A failure would be if the disease has progressed despite the surgery and further loss of function has occurred.
Okay. Now, this is the second time you mentioned urinary issues, and people at home are saying, okay, this is the neck and the spine. What does this have to do with this?
People are surprised to find out how much information is packed into the small area of the spinal cord. So entire control of arms and legs and bladder function are influenced by the nerves in the neck. That several centimeter area of tissue controls all of that. And so it's vitally important.
All right. Let's go back to our phone lines. Line 1, Carolyn is calling us from New Orleans. Carolyn, welcome. You're on Hello Health. Good to have you with us.
Hello. How are you today?
Wonderful, Carolyn. Thank you.
Good. My question is it an age limit to this surgery?
Good question. An age limit to the surgery, doctor?
There's really not an age limit or a hard and fast rule. As we know, once we get older than 70, the risks of surgery, any surgery in the spine, goes up. But oftentimes, the worse the problem and the older we are, the more you have a chance to benefit. So it really comes down to the individual patient. There's our chronologic age and our physiologic age, and I've seen 70-year-olds that look like they're 50 and vice versa. And so if you're in good health, take care of yourself, relatively trim, non-smoker, you may be a candidate for surgery even if you're older.
And that's an important point. In case you missed it earlier, that smoking has something to do with this disease. So
Correct.
if you want to lessen your chances of developing a cervical myelopathy, quit smoking if you do. Go back to our phone line. Stephen is calling us from Metairie this evening. Stephen, you're on line 2, and you're on with Dr. James Kalyvas. Welcome.
Hello?
Yes, go right ahead.
Yeah, I had an operation on my spine in 1999, and I have 6 screws and 3 rods in my back, And here lately, I've been having a whole lot of problems with my back and my legs. And I've been going to a gym for about a year and maybe 8 months, and I find it helps me out. But I cannot walk any kind of distance or stand up for a long time.
Let's see what the doctor has to say. So walking long distances is standing up. I think, by the way, our audio in the studio is a little lower than it needs to be. So if we can increase that just a little bit, that would be helpful to the doctor. But this is a gentleman who's having problems walking and long-term standing up after his surgery.
Can you describe what surgery you had, sir?
I had I can't remember that. L2 and 3 and 4, I believe. I got a cage with 6 screws and 3 rods. 6 screws, 6 screws, 3 rods.
I think you're referring to a lumbar surgery, the low back. Is that right?
Lower back, yeah.
Okay.
Which is not the primary focus of this evening, but the doctor may be able to help here.
Yeah, well, walking difficulty after a lumbar surgery is a pretty common problem. It is a little bit different than what we're talking about here because the spinal cord actually ends in the low mid-back. It doesn't extend down to the lumbar spine. So there's a whole host of reasons why you could be having problems with walking. If it's pain-related, it may be something to do with further degeneration. It sounds like you have a previous fusion with rods and screws. We know that that can lead to degeneration of other levels. By definition, with a fusion, we're making a previously mobile area of the spine immobile, and when you do that, the rest of the spine needs to take up more mobility, and that directly leads to further wear and tear. So it could be that you have further wear and tear, compression, or stenosis, maybe a term that you've heard before, and pinching of nerves elsewhere. It's a possibility. There are so many possibilities, though. It'd really be important to see your specific images and talk to you and examine you.
Thank you so much. We appreciate your question. Again, our phone number is 504-866-3200. Let's go back to the phones. Barbara is next, calling us from Metairie this evening. Barbara, you're on with Dr. Kalyvas. Go right ahead.
Hello. My husband, Royce Henry, had surgery with Paul Celestri in October, and they did the neck. They went through the front of the neck, and he was supposed to do the back, but it said not right now because he didn't wake. You know, he took a long time to wake up from the tube and all. So he still gets tired walking. He has trouble walking.
Mm-hmm. That's often the case where we plan to do both the surgery from the front and the back, so not an either-or situation, but we do both. And we do that for more extensive surgeries in the front that may require that a little bit of extra stabilization from the back. So that's a common thing. It's also common to stage the procedures. So if we are going to do a front and back surgery, we often separate them in time because surgery is a trauma. In and of itself, it's a trauma. And so we want you to get over that. And if there was difficulty with the first surgery, all the more reason to wait with that. So I think it sounds like appropriate care. I'm sorry to hear that walking is still a difficulty.
And how many cases would you be doing both anterior and posterior?
It's pretty uncommon, but for example, we mentioned earlier about a corpectomy. That's where you remove an entire vertebral body. That would be appropriate if you had a really large osteophyte or bony spur just behind the vertebral body, for example. We see that when the ligament there becomes calcified. In that circumstance, maybe it's appropriate to remove everywhere there's compression by doing a corpectomy. And often is the case where we do a corpectomy and we do posterior fusion as well to stabilize things because we've removed a lot of bone.
Our guest tonight is neurosurgeon James Kalyvas, and tonight we're talking about cervical myelopathy. We are taking your questions at 504-866-3200. That's 866-3200. Doctor, here's a email question we received. I had the surgery 7 years ago. It doesn't say which one. Am I at a greater risk for developing arthritis? Also, will I see a decrease in range of motion as I age? So the first question is arthritis and then decrease in range of motion.
It's a very, very good question, one that I get all the time. Arthritis is the wear and tear of getting older, and so that process isn't going to stop whether you've had surgery or not. But what I was referring to that previous caller was when you have a fusion surgery, it often causes acceleration of the degeneration of other levels. We know that to be true. So in some sense, yes, having a fusion surgery can increase that, can accelerate the degeneration.
But would that be enough to say don't do the surgery?
No, because the spinal cord and preserving the function of the spinal cord is the most important thing. Not all degeneration leads to compression, but where we see that, we have to prioritize it and protect it.
Okay. You mentioned you get that question often. What other questions do you get that we haven't dealt with this evening?
I think most patients are surprised that I would recommend a surgery on the neck if they don't have neck pain. And so understanding that neck pain is not always associated with this problem. It's really hard to understand and internalize, and I acknowledge that. They often go hand in hand because when you have wear and tear on the neck, you often have neck pain. But you sometimes can have problems in the spinal cord with no neck pain at all, no arm pain, and you wouldn't know you had it except that you went to the doctor and described things like dropping objects and gait problems.
Okay. Here's another question, email question, Doctor. What percentage of patients still have symptoms after surgery?
The majority of patients still have the dysfunction of cervical myelopathy that they had going into the surgery. And about 2/3 of patients will get better over time in a year. But the overwhelming majority are stabilized. There are very few situations where things get worse. It can happen, but by and large, stabilization is a pretty expected result from a successful surgery.
You mentioned this is a wear and tear issue, so most of your patients are going to be older. What's the youngest patient you've had to work with, and what's sort of the range?
Well, the youngest was an unfortunate case of a 2-year-old girl, and this is a case I did with Dr. Celestri of orthopedic surgery. She had a slightly different problem where she was born with only half of a vertebrae in the neck. And so she had kyphosis, or bending of the spine, and the spinal cord was draped over that spine. And so she was 2 years old, and we did a corpectomy in that case for myelopathy, and she did quite well.
Again, our phone number is 504-866-3200. That's 866-3200. When you go into a surgery, so you've done all these tests we talked about earlier, do you have a roadmap? Do you know exactly, you obviously have a pretty good idea of what you're looking for. How often do you get surprised that something didn't show up, that you have to take a detour here or there?
I'm generally surprised by patients. Patients surprise me all the time. The pathology is fairly cut and dry, although I will say that the pathology itself is pretty variable from person to person, and it presents in everyone differently. You can imagine that the spinal cord has lots of different function in it: motor function, sensation, pain and temperature, balance, and the urinary control that we talked about. And so one person's compression of one area of the spinal cord may look entirely different than someone else. There's also a lot of overlap with other diseases. So not all the time, but pretty often I'll see patients with MS, for example, who also have compression of the spinal cord. And then it's up to me to sort of decide what of these symptoms do I think are attributed to the MS and what are attributed to the myelopathy. So surprise isn't necessarily the right way, but it's not cookie cutter all the time, and it takes a little bit of experience with it to really know.
Let's go to the North Shore now and back to our phone line. Sharon is calling us from Covington this evening. Sharon, welcome, and thank you for your patience. You're on with Dr. Kalyvas.
Hi, yes, thank you. I have a couple of questions. I've been treated recently for pain in my neck, and I also have discomfort at the top of my back. I think it's coming from my neck, and I do have a problem with the reflexes.
So what would you recommend? And have you been to see anyone, Sharon, about all this?
Recently, the pain management doctor treated me for the pain.
Where would you recommend Sharon turn?
I would start with seeing your primary care physician for a good basic physical exam and workup, maybe even including an MRI. It's important to realize that even though reflexes may be associated with it, there's a certain percentage of the population that has exaggerated reflexes with no problem. More important are the reflexes symmetric, the same on both sides, or do you have an exaggerated reflex on one side where you don't on the other? And those are things that your primary care can really look at, and if they think it's appropriate, refer you to a spine surgeon.
And that would be the next step. So what percentage of patients nobody's starting with you, they're starting with their primary care physician?
Yeah, by and large. I have some patients that are just, look me up and schedule an appointment. But by and large, these are people that are concerned about their neck pain or some of their symptoms, maybe shooting arm pain, maybe some of the things we described. See their primary care physician and then come see me, often with an x-ray only. And then it's my job to figure out what the correct tests are. Usually it's an MRI.
Okay. You mentioned you might do 2 of these from the front a week, 2 of these from the back a week. Mm-hmm. What are you doing? Not that these aren't important. What are you doing with the rest of your week?
Well, I see a lot of patients in clinic for a whole range of spinal problems. I have a particular interest in complex spinal problems to do with alignment. So you may have heard of scoliosis. So I do quite a bit of scoliosis surgery. I'm interested in spinal tumors. So I see patients with a broad range of spinal problems. And I'm operating 3 days a week, and it keeps me pretty busy. And when I'm not doing this, I'm at home with my new 4-month-old.
There you go. We talk about robots and surgery often on this program. Is this an option in either of these surgeries, or do you see that day coming?
Potentially. Potentially I do. There are some robot systems that are out there for the lumbar spine and the thoracic spine, so that's the mid and low back, mostly to place some of the screws that we saw in the pictures. But it's just not advanced enough yet. It's just not there yet. I think eventually it will be. The biggest advance we have right now is intraoperative CAT scan guidance of our hardware. So whereas before we would use just the patient's anatomy to figure out where to place the instrumentation, in some cases, the more complex ones, we'll do an intraoperative CAT scan and actually have our instrumentation guided by the pictures in real time as it's corresponded to the patient's anatomy. And that's really done a lot for the accuracy of our instrumentation.
All right. Let's go back to our phone lines. Again, our number is 866-3200, 866-3200. We do have a couple of minutes left and time for your questions. But let's go to Ernestine, who's calling us from AMA this evening. Ernestine, you're on line 2, and you're on Hello Health. Good to have you.
Okay, I have cervical stenosis, a bulging disc, and, of course, arthritic degenerative changes. My question is that I have also neuropathy in my hands and feet. And is that related to the neck problems?
That's an excellent question. The short answer is probably not. So the most common cause of neuropathy or a problem with the peripheral nerves, okay, in the arms and legs, is actually diabetes that's not well controlled. I don't know if you have diabetes or not, but it's a little bit of a separate problem, comparing peripheral nerves to nerves within the central nervous system. There is some overlap in the symptoms. For example, numbness and tingling can be a sign of either. And in those cases where it's unclear and the MRI doesn't really answer for us, we'll often get what's called an EMG or a nerve conduction study to help us figure out. And that helps localize where the problem is. Is it in a peripheral nerve or is it central? And then it also tells us which level within the spine is most affected. So.
Okay. Again, our phone number is 504-866-3200, 504-866-3200. Doctor, here's another email question. As I watched the video clip at home of the surgery, I wondered, what are the chances of the spinal cord being compromised? I often find, okay, so we'll stop with that question right there.
So by compromised, I assume injury to the spinal cord during that procedure. You know, that's why you need to be an experienced surgeon. You want someone who's done this and does it regularly. That's something always in the back of our mind is damage to the spinal cord. It certainly can happen. It doesn't happen frequently. But one of the things we do, aside from meticulous detail and being careful, is monitoring the spinal cord function in surgery.
Okay. This may be a tough question, I don't know, but you mentioned residents are in there with you in the surgery. And so every patient wonders, okay, the resident is there to watch, the resident is there to learn. At what point does the resident get actual experience? Or is this kind of, so you just talked about the delicacy of this and you want a surgeon who does this all the time. Are you ever saying, here, you take it, Bill, or Susan, your turn?
Yeah. That is a difficult question to give a blanket answer to. You know, training is a vital important step in every surgeon's life. You don't get to become an expert until you've done it a few times. And Ochsner is a teaching facility, so I never shy away from telling patients that residents are involved in the surgery. They're never taking the lead. They're never unsupervised. They're never doing the primary moves. They're not doing the risky moves, but they are involved and they're helping, and I would say, you want them involved. That's the way we do things. And any deviation from how we normally do things actually sets you up for more risk. And so they're a vital part of the team, and they're intimately involved.
Can you look back at your own training in your own residency and in your own fellowship work and see where you were flying the plane for the first time or making those intricate moves and procedures for the first time under someone else's watch?
It's a much more gradual process than you might think. You're not just left alone to fly the plane. You know, you get graduated responsibility over time where you don't even really realize how much more responsibility you're taking until eventually you are doing some of the complex stuff under direct supervision. It's a very gradual process, and the training is over 7 years or 8 years with a fellowship, and that's a long time. You know, a lot of these residents I would trust to do my own surgery just because they're pretty experienced at this point.
Good. All right, here's another email question. Doctor, I find the need to crack my neck. Is this bad for me? Could this lead to further damage?
I've not been asked that question before. It's a little bit like cracking your knuckles. I guess it can lead to more arthritis, more damage, more wear and tear.
When we say cracking the knuckles, or in this case cracking the neck, exactly what's happening? And I've certainly heard this described before.
Yeah, it's just air within the joint that's being released. And so if you have a loose joint and you crack it, the maneuver is just squeezing air out of that joint. But it's more a sign that there's degeneration than it is a cause of degeneration to crack your neck.
So not something you'd recommend, but also not something
not something I'd recommend, not something I'm particularly concerned with.
All right. Again, for patients who may just be joining us halfway through, what message were you hoping to get through tonight? So kind of recap the definition, cervical myelopathy, and the options available to treat this.
Cervical myelopathy is a disease of getting older, wear and tear, where you have compression of the spinal cord from all of the things that also may cause neck pain or arm pain. In severe situations can cause compression of the spinal cord. And the symptoms that we classically look at are hand clumsiness, balance problems, and urinary problems, urgency or incontinence, and so forth. And it can be a painless disease. And so I would urge people to be on the alert for those sorts of things. If you have spine problems and you've noticed these things, no one's asked you about it, it may be something you want to ask your doctor about. I would say that while this is a common problem, I actually think it's underreported and under-recognized by physicians. As I mentioned to you before, I see a lot of patients for low back pain, and I see plenty of patients that come in for low back pain and end up needing neck surgery.
So the numbers show us about 200,000 a year, but you
Right.
think
I think that
numbers are much
underreports
higher
it.
than
I
that.
do. And as we get older, that number is going to go way up.
All right. I want to thank the doctor, Dr. James Kalyvas, for his expertise and education tonight and for his work in the Oxner Health System. Thank you so much,
Thank you
Doctor.
so much for having me. I
Great
had a
to
great
have
time.
you with us. Yeah, a real pleasure. Well, to make an appointment with any Oxner physician, including tonight's guest, or to register for any of Oxner's Hello Health seminars, or to suggest a topic for this program. We're going to throw that out this week. If you'd like to suggest a topic for our Hello Health program, here's a special number set up just for you. 504-842-5669. That's 504-842-5669. Again, that's to learn more about our Hello Health seminars, or suggest a topic, or to make an appointment with any physician, including tonight's guest. As a reminder, you can rewatch tonight's presentation or any of our Hello Health programs on our website at WLAE.com. Oxner's website has lots of our programs too. That's at oxner.org. Our thanks again to tonight's guest, Dr. James Kalyvas. Thanks to Humana and Oxner for making this program possible. And our final thanks, as always, is to you for your support of our program, Hello Health, and our station, WLAE. Good evening.
Hello Health on LAE is presented by the Oxner Health System, a nonprofit academic multi-specialty healthcare delivery system dedicated to patient care, research, and education. The Oxner Health System includes 8 hospitals and 38 health centers located throughout southeast Louisiana. Oxner, healthcare with peace of mind.
When Rose first started with us, she was just coming out of the hospital.
It's been a better situation. I can always depend upon her to help me. I'm home, and that makes me happy.
We're here to get her back into her routine and be able to live the life she wants to live. It's an honor to be trusted with that responsibility.
Usually 1 year. You have to be accepted. You're competing with other people who...
You apply and you're competing.
Okay. All right, here we go. Hi, I'm Tom Bagwell, inviting you to join us on Monday, May 1st for your next appointment with Hello Health. We'll be talking with neurosurgeon James Kalyvas about cervical myelopathy, a condition caused by the narrowing of the spinal canal, and that can lead to serious spinal cord issues. Our next Hello Health, presented by Oxner and Humana, is Monday night, May 1st at 7 o'clock, right here on WLAE. Music, graphics, cold turkey? Okay, sounds good. Hi, I'm Tom Bagwell, inviting you to join us Monday, May 8th, your next appointment with Hello Health. We'll be talking with psychiatrist Jennifer Vellender about addiction, the different kinds of it. Are some of us more susceptible to others to getting addicted, and today's treatment options. Our next Hello Health is presented by Oxner and Humana. It's Monday night, May 8th at 7 o'clock, only on WLAE.